Good morning, everybody. Welcome to the second day of these training school webinar sessions. Yesterday, we were glad to enjoy the lectures from Paulo Sosa and Bojana Gnecevic. Today, we have two more lecturers, Reinhard Strametz from Germany and Andrea Jekova from Slovakia. Thank you so much, both of you, for your participation today. Please, to all of that you are following us via YouTube, please remember that all the webinars have their own link, so you will have received two separate links and check it on your emails. So let me introduce the first lecturer of today, Professor Reinhard Strametz. He was head of quality at Frankfurt University Hospital. Today, he is professor of patient safety at Wiesbaden Business School in Germany, also General Secretary of German Coalition for Patient Safety, and of course, Vice Chair of our Cost Action, the European Researchers Network working on second victims. Professor Strametz, many thanks for being with us today, and the floor is yours.
Good morning, Amaya. Good morning, everybody. Thank you very much for sharing the time with me and giving me the opportunity and chance to talk about the second victim phenomenon. And also, Maya, thank you very much for your kind introduction. So, talking about the second victim phenomenon, we have to assume that during a patient harm or a medical error or any unanticipated clinical event, there is much more than one victim. Of course, if a patient gets hurt, if a medical error occurs, if an anticipated clinical event occurs, the first victim will be the patient or their next of kin. So this is without any doubt, and during the presentation, this is always in the room when talking about the second victim phenomenon. In the year 2000, Albert Wu coined the term that the doctor who makes a mistake needs help too, and therefore should be considered to be the so-called second victim of any medical error. This term he coined has now over 1 million Google entries if you Google this term. So it's been established in research and also clinical practice all around the world, and it's the theoretical basis on which the European Researchers Network of Second Victim is also based upon. I think it is very important for Albert to mention that he didn't invent the second victim phenomenon, so there will always be second victims. So if you want to look for any creator of the second victim phenomenon, if you trust in God, it may be God itself, but as long as medical treatment is there in history, in human history, there have always been second victims, and of course there will always be second victims if something goes wrong, and healthcare professionals could be traumatized upon this. Another important fact is that in the meantime, it's also clear that there are not only second and first victims, but there may be also third victims, like the organization in which something bad will happen, or even some other uninvolved staff might get traumatized or might face negative effects during any unanticipated medical event. So we have to keep this in mind. This does not lower the impact for patients or next of kin. So it's important also to face on their needs and to address their needs, of course, in the same way as we have to address the needs of the second victim. But we, of course, and I will tell you why, have to consider to help second victims if they get traumatized. So in the meantime, after this editorial in British Medical Journal by Albert Wu in 2000, which I highly recommend you to read, there's another important research, also mainly done by Susan Scott, starting with publications in the early 2000s, And I highly recommend the key papers of Susan Scott and colleagues, like Caring for Our Own, and a lot of theories and concepts for the cause, the aftermath, and the treatment of second victim are based upon this research. And as you see, the definition of Scott has a more broader approach to define second victim. It's not a medical doctor anymore exclusively, and I think everybody's fine with this definition, but it's any member of a healthcare team. So any healthcare worker involved in care could be traumatized and victimized by an anticipated patient event, which could be a medical error or a patient-related injury. And in this case, he or she could become victimized in the sense that they are traumatized by the event, by the special event. So this broadens our definition and our understanding of the second victim phenomenon. And it's not only the medical error leading to any catastrophic event that can cause second victim traumatization, which we have to keep in mind when screening for second victims and caring for second victims. So first of all, and if you finish this presentation and you only remember one key point, then I would like you to remember the key point that second victims need help instead of punishment. And I will try to show you why, based on the growing body of evidence also members of Ernst are creating before, during, and of course after the COVID-19 pandemic. So looking at surveys, looking at systematic reviews that are recently confirmed by other researchers as well, up to 1 in 2 healthcare workers reports on second victim traumatization in surveys. And what is most important to me, these surveys normally focus on research based on experiences during the last 3 years. So it's not anybody remembering any incident 30 years ago in their professional career, but recent incidents in their professional career. And up to 50% of healthcare workers report on being second victims. This is a growing number in the last years, and to my experience and to my hypothesis, it's about a reporting bias in previous years, and the demarcation of a stigma. So it's much easier to talk about second victim phenomena in those days than it was about 10 or 15 or 20 years even ago. And some own research we conducted in Wiesbaden together with some colleagues from the Berlin Charité and the German Federation of Internal Medicine was the so-called Save It One study. Some key elements that can be added to the body of evidence of second victim phenomenon research is that we asked young professionals during their medical specialization in internal medicine whether they would know about the term second victim or the second victim phenomenon. And roughly 1 in 10 of those doctors answering the survey did respond, yes, I know the term and I have heard about the term. But after giving the definition of a second victim phenomenon by Scott, roughly 6 of 10 of the participants reported that they have been traumatized by themselves during their medical education, so within the last couple of years. This is for me, it's an important issue that we are talking about something most of our clinicians, and we also did this with nurses, will be published within a couple of days, I hope, with the SVT trial, and also with nurses, that a lot of people being traumatized, being second victims, don't even know the term or don't even know that there's a natural cause of second victim traumatization, which might explain the next slides and the data that will follow in the next slides. So some more evidence about the second victim phenomenon. So experts, this is a paper from Switzerland. Experts assume that every healthcare worker will be second victim at least once during his or her professional career. So it's a very, very common phenomenon. So it's, to be honest, it's the normal situation right now in healthcare systems. As Don Berwick, for example, pointed out, that we have good people in bad systems, and good people in bad systems sooner or later will fail and might be traumatized. And another number we have to keep in mind, have to consider, that was recently confirmed with our SVT1 and SVT2 trials, is that although some of the second victims will cope very fast with this traumatization and report that it took about a couple of days to get back to normal, up to 20% of all second victims state that they didn't recover from this incident, from their key incident at all. So that they are walking wounded, and they will consider themselves to stay wounded due to their professional career and during the rest of their professional career, as well as during the rest of their life. What happens to second victims? And this figure I took from the Candor content from the Agency of Healthcare Research and Quality in the US, is also based on the studies of Susan Scott and colleagues, which did some qualitative interviews with second victims. And they realized that there are typically 6 stages from becoming second victims until you set up your coping strategy. And I won't focus on every detail, as I highly, again, recommend the paper of Susan Scott and colleagues that describes this stages of second victim traumatization. What is most important for me is that they found out that there are 3 possibilities how you can cope with a second victim traumatization, how you will react on a second victim traumatization. And there's growing evidence showing that the direction you will choose is highly dependent on the amount of support you will get during these 6 stages. So the best way of reacting to a second victim traumatization would be growing with the situation, to go on, to move forward, and to learn from your experience, and to coin this experience to a positive learning message you have for yourself, and that you may also use as a patient safety ambassador in order to make systems safer. So that although there might be a key incident that has traumatized you and also patients and their loved ones, that you will learn, and that you can take this learning message to make systems better, to move on. So this would be the best possibility, of course. Then there's the so-called surviving, that you will stay in your job more or less wounded with some dysfunctional coping strategies. I will tell you in a couple of seconds, so that you move on anyway, but in a non-functional or less functional and less effective way than before. Or there could be the dropping out, either that you leave your profession, or that you turn over to another profession in the medical field, not treating patients anymore. There are unfortunately a lot of careers, even of successful clinicians and nurses, that were in their jobs for 20, 25 years, that had to drop off from one day to the next day as they were not able to cope with the situation. And there may be even more dramatic dropping outs, I will tell you right now. So based on the study from Amy Waterman and colleagues, which were an eye-opener to me in a certain way, we see that the fear of harm of professional reputation, which is intended to be the most eminent threat to clinicians if they make a mistake, is not the real problem at all. So it's more about the loss of self-confidence, the increased anxiety about future errors, that harms healthcare workers becoming second victims. And what is very important to me, if you look at the graph, is that you see, of course, serious errors have an increased likelihood of becoming second victim and of having a high burden of disease of this phenomenon. But also near misses, critical incidents that didn't cause any patient harm, so that did not cause anybody to be first victim, or may not cause to create first victims at all, can still cause second victim traumatization. So one story that will be in my mind for forever is that I'm in my former life, I was a lifeguard, a voluntary lifeguard of the German Life Rescuers Association. And we in our swimming pool, we had a recovery of a 3 or 4-year-old boy who was drowning, and we successfully resuscitated this child, which was perfect, which was a history, a medical history that can be compared to American television series like Baywatch. But the people involved in this rescue had to cope with the situation, although it was a successful treatment, a very successful treatment, for months until they got psychological support and help, because they had flashbacks every night of the situation. So the result of a medical treatment is not necessarily correlated to the impact of a second victim traumatization. So second victim leads to dysfunctional mechanisms, as 2 of 3 second victims show more or less dysfunctional coping strategies, which could be isolation, self-isolation, as there's a lack in the confidence, depression and anxiety, of course. Also, substance use is very common among second victims, and it's a problem as you can easily access maybe some of the substances you will abuse. Defensive medicine is another very common problem, that you become anxious and you practice defensive medicine, which is not good for future patients you treat. There's even a lot of cases who develop post-traumatic stress disorder, job turnover, and in the worst case, and we have to mention this, and if you consider yourself to be a second victim, as this trigger warning should be mentioned, please consider seeking help right now, because unfortunately, in the worst case, second victim traumatization may lead and has led in many cases to suicide as well. So if you are affected by this, please consider seeking help immediately, as there is help in the situation. So the systematic aftermath of second victim phenomenon can be seen on several bases. Of course, for staff being traumatized, it's an acute health hazard. So I think I made this clear. And we talk about reduced quality of life and job satisfaction as well, maybe for years, maybe forever. For future patients, it's also very dangerous. As I'm General Secretary of the German Coalition for Patient Safety, we say that healthcare worker safety is patient safety and vice versa. So a lack of empathy to future patients and increase in errors and deficiencies, which can be caused by defensive behavior or even paradox aggressive behavior, may harm lots of patients after the key incident has happened. And of course, for the organizations, it's also very disadvantageous, as increased turnover can happen. And of course, even if second victims are not supported well, it can have a dramatic impact on the safety culture in total for these organizations. So you may ask how COVID has affected the situation, as some of the people I talk to think that second victim is a COVID-specific phenomenon. Although we have to state that during the first SARS epidemic in 2003, up to 50% of healthcare workers showed signs of acute psychological distress, including burnout and PTSD. We have to state that this, of course, may also happen during the COVID-19 pandemic, as it's not so acute like SARS-CoV-1, which was managed within a couple of months, leaving only a little bit more than 1,000 deaths. But during the SARS-CoV-2 pandemic, which can be compared to a marathon rather than to a rush, the healthcare workers have suffered of permanent load, at least the fear of triage or triage in some areas of the world, indeed, and this had an enormous additional impact on healthcare workers. As most of the evidence was created before COVID-19, we have to assume that nearly every healthcare worker was traumatized during COVID-19. So in this case, we have to systematically support them before COVID-19, during COVID-19, and of course, also after COVID-19. And I once again would refer to the work of Susan Scott. She and her colleagues established the 3-tier model of peer support, which is very, very common and which is evidence-based due to the studies of Albert Wu, of the RISE program, of Susan Scott, of the 4U program, and other programs as well. So the first thing and the most common support that is needed is the support by peers who understand second victims, who speak their language, who know their situations. Identifying second victims, showing understanding, avoiding bullying, and if necessary, referring them to a crisis intervention team. The next step would be the crisis intervention professionals, accessible 24/7, which offer a direct and confidential support. To the studies of Susan Scott and colleagues, roughly 60% of all second victims can be sufficiently treated and helped with a tier 1. Another 30% need tier 2, and about roughly 10% of all second victims need a professional support network with maybe also long-lasting crisis intervention and psychological therapy and treatment. So if you support second victims right, roughly 2/3 of all second victims won't need any professional help at all outside your peer support in the department. So we should really consider to train not only for the somatic diseases first aid support, but also to train psychological first aid among healthcare workers in every organization. There are a lot of suggestions and a lot of evidence-based interventions to reduce the impact of second victim phenomenon, which also can be found in the work of Susan Scott. Also for the German region, David Trappach invented these suggestions. As you can see, it's about understanding, it's about helping. It's also about detecting why things went wrong. So also do a case analysis, also do a hazard analysis, maybe a London protocol or error and risk analysis to understand why things went wrong and how things can be prevented, which may also help second victims to cope with the situation. But besides the strategy of treatment of the second victim phenomenon, I think we need a two-pronged approach, as we also should increase our efforts to prevent people from becoming second victims, which of course can be done with patient safety standards, because if the patient is not harmed, if the treatment gets right, there are less second victim traumatizations happening, but also by enforcing the resilience of healthcare workers. And this is a graph from our open access available brochure about maintaining capacity during COVID-19 pandemic. And it refers to the 3 dimensions of resilience from Aaron Antonovsky: meaningfulness, comprehensibility, and manageability. And if you see that these are strategies suggested during the COVID-19 pandemic, and if you look closely at the possibilities we want to give the healthcare workers, we should add to this graphic reinforcing clinicians' resilience during and, of course, after the COVID-19 pandemic, because everything we put up here is not especially referring to the COVID-19 pandemic, but should be the vision of a resilient healthcare organization and a place we as clinicians would love to work also in the future. So leadership on resilience, crisis communication, clear and informative uplifting information, and continuous support of staff is nothing that is exclusively related to the COVID-19 pandemic. COVID-19 pandemic was a magnifying glass and also, to my opinion, a chance to set up things right and to take a break and to reinforce resilience whenever necessary. So I will take a break and a team timeout as well, with a nice picture of a Bavarian sea I once visited. And I would like to thank you for listening to this presentation, and I am very much looking forward to any of your questions. Thank you very much.
Thank you so much, Reinhard, for this interesting presentation of today and to clarify some terms of the second victims phenomenon. Here are some questions of the participants. So may we have a little debate now. So first of all, as we know, we have suffered this COVID-19 pandemic, and it has changed not our personal life, but professional life, and of course in healthcare area. So do you think that the treatment of second victims will change? There will be an evolution after this situation?
I hope so, and I think we will do as we all face, to be clear, we all faced a global psychological crisis, everybody all across the world. And now it's possible to talk about psychological impact of healthcare workers. So in the first phase of the COVID-19 pandemic, nurses and doctors and healthcare workers at all, as many other professions, were seen as heroes. But the problem with heroes is that we expect from heroes to be the hero, to suffer for us, and to get up things right. A hero has no right to be depressed, to be anxious, to be exhausted. So I think we should move on from this heroic image to the image that healthcare workers, first of all, are human beings with human needs. And I think it facilitated, the whole COVID-19 pandemic facilitated discussion about healthcare workers being human beings and having needs and needing support. So to make this clear, showing signs of weakness is all human, and it's not a sign of weakness to speak up for your own health worker safety, but it's a sign for responsibility, and it evidences professionalism to speak up and to say, I need some help as well, in order to treat my patients best also in the future. So I think COVID-19 has changed, but I also fear that if COVID-19 is over, there are a lot of mechanisms that falling back into the old perspectives and the old habits. So we should really use this window of opportunity to set up new things and to maintain good things we have established during the COVID-19 pandemic, as we are forced to do.
Okay, thank you so much. Totally agree with that. And do you think that should the organization also be involved in this change and in this and maintaining that healthcare of the healthcare workers is also important?
Yes, of course. So if you look at the somatic problems, we all are trained in first aid. So in Germany, if you want to have a driver's license, you have to have a first aid training in order to help people who have an accident, for example. And also in hospitals, there of course is a tough first aid system, like if somebody needs CPR, for example. And I think we should also train psychological first aid, which of course is established in some other disciplines and branches. If you look at the train industry, the aircraft industry, if you look at emergency medical services, there have been such quick response teams established. For example, if you have a train driver and you have somebody who's in front of the train due to a suicidal attempt, there is a mandatory requirement from the European Union that those people have to have the right to get immediate psychological support. But there's no directive for healthcare workers. And I think also the European Researchers Network working on the second victim phenomenon is working very hard and, to my experience, also successful to change this, that every healthcare worker has the right to get psychological support, that being traumatized psychologically by any event could be also regarded as occupational accident. Like if you slip on a wet floor in the hospital, for example, and you break your leg, it's also an occupational related injury you should get support from. So I think this should change in general, and it's not about the intensive care medicine or emergency medical services, as there's growing evidence from all specialties in medicine and in healthcare treatment and healthcare sectors. This is a common phenomenon that affects every healthcare worker, no matter who or where she is or where he or she works. So I think this common understanding will be rising within the next few years. And I'm very proud that the European Researchers Network working on second victims will have a huge impact on this development.
Okay, and if we have one, well, we're talking about the actuation in hospital, but maybe we have here a question in the chat box. What about our personal contacts? If we have any colleague that's been traumatized by some kind of accident or adverse event, how can we, as personal approach, help him or her with that situation?
Yeah. So of course, everybody is different and the traumatization is different. But I think the best choice would be if somebody would come to me and tell me about his or her problems. First of all, to listen, to give him or her the opportunity to speak, free of bullying, free of any assault, to hear what he or she has to say. First of all, to confirm that if a medical error, for example, happens, or if somebody is traumatized by any unanticipated clinical event, that this is normal, that it's not about his or her fault or disability to perform in the job, and to ensure his or her professional competence, and to strengthen this. To, of course, offer support, and maybe to ask him or her whether a referral to any professional help, professional support strategy could be helpful, also to assure him or her confidential treatment of this, and to say that this is normal. So I've talked to a lot of colleagues. I was anesthesiologist for 8.5 years at Frankfurt University Hospital as well, before going to the quality management department. And I talked to a lot of colleagues who were affected by such phenomena, and to speak with them, to listen to them, to assure them that it's not that they are professionally working, that they are respected colleagues, helped a lot just to cope with the situation. So I think this is the first choice. Of course, this support should be added with some systematic and professional help. But first of all, you have to establish these structures. So if I'm in a hospital and somebody comes to me asking for support, I should know which phone number to call, and to ensure that this person is being helped within a couple of hours or days. As some support strategies also in Germany have big capacity problems due to COVID-19 and other circumstances. And it's important that those people get help quite fast, and that they are able to speak up fast, not to cover this and to bear it with them for months until they get professional help. So this would be the first choice. And I also recommend, if you're interested, to the German Coalition of Patient Safety and the Austrian Patient Safety Network has published some help of reinforcing clinicians' resilience. Some of the graphs I showed in the presentation, it's you can download this free of charge, open access, and there are a lot of suggestions how to help second victims, not only during COVID-19 pandemic, if you want to do this on your own before referring anybody to professional help.
Okay, so nowadays there is a current psychological program in your country. We know that each European country has a different law, but in Germany now, is there any psychological program to help care workers?
So there's no statewide program, which is normal because organizing healthcare is a statewide task. So every of the 16 states of Germany has to organize healthcare. There are some states in which psychological support is organized very professional, like in Bavaria, for example. Every clinician, no matter whether he's working in hospital, he or she's working in hospital or in other sectors, has a telephone support hotline, which can be accompanied also by a in-person psychological support. There is no nationwide system right now, and there are many local initiatives, especially at larger hospitals, who also have psychological departments or psychosomatic departments. But also in Germany, which is considered to be a very well-organized healthcare system, there's a big demand of establishing systematic professional psychological support for healthcare workers especially if you look at the primary sector, for example, or smaller hospitals or other branches. So there's also still a big demand, and we are also in Germany working hard on establishing such structures that every healthcare worker has the possibility and quick access to such support strategies. There's no nationwide implementation. And even in the US, where there are these pilot projects at Johns Hopkins University or the University of Missouri, there's also no nationwide support program that is mandatory, to my knowledge. So we still have a lot of work to do worldwide to improve the situation for healthcare workers.
Of course, yeah, and regarding also in the law section, because one last question is about if there is any emotional burden if the medical or nursing profession taken as an occupational hazard in Germany.
So regarding to occupational hazards with somatic traumatization, maybe. So there's a very strong occupational medicine in Germany, considering somatic disciplines. But the traditional occupational medicine is purely somatic, and there were some efforts in the last years also to make some process evaluations about psychological burden during work, as psychological diseases are increasing, and the sick leave for psychological diseases increases in Germany as well as in, I think, any other European country. But it's still an emerging field, as it's not a classical domain of occupational health care. And although there are some systems implemented, like if you have a traumatization during one shift, you can get psychological support, and it's also being paid by the occupational insurances. There are, of course, a lot of burdens to talk to other colleagues, or even as a doctor, for example, to talk to any psychologist, as we are still trained to be the doctors, to be the heroes, to be the ones who are healthy, and the patient is the one who's ill. So I think there's a lot work to do to convince our colleagues that it is normal to be impacted, and that it is normal to seek for some supervision, to seek for some psychological support. As psychologists and psychiatrists, for example, regularly use supervision in order to stay healthy and confident and satisfied in their jobs. So there's a lot of work to do, but of course there's a stable basis we can build this on. And I think it should be one of the healthcare workers' rights to get such implementation. And I'm very happy that also the Global Patient Safety Action Plan by WHO, which was released in August, also very recommendable, also focuses on healthcare worker safety. For example, because of the need for personal protective equipment, which is without any doubt also important, like FFP2 masks and everything like that, but also the psychological protective equipment they need by psychological support for their work.
So we have reached the end of this fantastic webinar. Thank you so much for all your questions. Thank you so much, Professor Reinhard, for being with us today. Hope this kind of lectures will guide us to have a better healthcare workers policies, and of course put a little sight on second victim phenomenon. And now next we are going to have a break. We will see you with next webinar at 11 a.m. with Professor Andrea Jakova. Please, if you have any doubt or you would like to know more about our cost action Ernst, you could write us on info@costernst.eu. Thank you so much for being with us today. Bye.